everyone, welcome to Science Friday.
Here's some for E as well. The one on the top here is one of the ways that you can define E.
What makes a field more likely to have an unbalanced gender distribution?
So this can be, like, in the case of this paper, gyrification or brain folds.
A neuroscientist started to look at the brain
as like the
more as an
incredibly negative
my name is Colin, and I'm going to be presenting on pharmaceutical industry. So, why am I interested in this? My old school, elementary school in 3rd grade, and a bunch of my friends went to different schools around the Bay Area. So I wanted a way to keep in touch with them while we all kind of split apart. So we participated in an after-school science program in which we 6th grade. Our teacher was named Lisa. Was a great mentor to me she was diagnosed with stage 3 brain cancer and ended up ultimately passing away in 2018. And because of that, and because of how important she was to me, and the kind of feeling that someone that important, as someone I respected and loved so much, could be taken away from me that quickly, I wanted to learn more about cancer in general and how you can combat and treat it. So I was inspired then to look for opportunities over the summer to research cancer and cancer pharmaceuticals. So I ended up taking an internship at a company called Coherus Biosciences, in which I did research on antibodies that were involved in cancer treatment. But that drove me to this main question for my time over the summer and this presentation. When you're researching different drugs, how do you know which one's the best? How do you know which candidate of the hundreds you have is going to be the one that you're going to produce at scale? And how do you know how much to administer and give patients? So this guiding question led me to a couple interesting discoveries. But before I can get to that, I need to discuss what is cell mortality. So this might be a little counterintuitive, but you want cells to die when they're told to. In your body, every day, thousands and millions of cells are essentially killing themselves when they're told to. And the reason that they do this is because if they have DNA damage or get too old to complete their function, they're told to die, which is called apoptosis. But when cells don't do this, and they can not do this for a couple reasons, but they can become cancerous. And that DNA damage can spread and grow in tumors. But this is also kind of why most people have cells with DNA damage that some people might consider cancerous, but aren't really a threat because they don't behave in this way. They are mortal, and therefore they die when they're told to. PD-1 is a protein that binds to the PD-L1 receptor on cells. And when it's bound to this PD-L1 receptor on a cell, that cell becomes immortal. It no longer responds to signals from T cells in the immune system to die. And this is generally a good thing because it helps prevent overreactive immune responses so that T cells don't kill too many regular cells. And it can also help when cells just aren't supposed to die at all. So when does this become a problem? This becomes a problem when cancerous cells hijack and exploit this PD-1 protein and grow PD-L1 receptors when they shouldn't have them. So there's a way to target PD-1. And when you have an antibody targeting a protein, usually it's referred to as anti that protein. So in this case, it's anti-PD-1. So if you have a cancerous cell that could be bound to by PD-1, if you create an antibody that binds to PD-1 before it can get to that cell, you limit the amount of immortal cancerous cells that you have, which is generally a good cancer treatment in conjunction with other treatments like chemotherapy, because it helps weaken the cancerous tumors and make them more treatable. So I was focused on a drug called sintilimab, which is an anti-PD-1 drug, as we've discussed so far, And it's an antibody, so it binds to that PD-1 protein and prevents it from binding to cancerous cells. This is a preclinical characterization, which means that before you move into clinical trials, you want to know how tightly that antibody binds, which can give you great information on dosages. Because the tighter that antibody binds, the less you'll have to administer, and therefore not only the cheaper the drug is, the more effective that drug is. It also, given these characterizations, you can also determine which antibody will be the best for targeting this antigen. So if you have PD-1, for example, there are going to be hundreds of different antibodies that can possibly target that protein. But one of them will be better than all the others in terms of how tightly it binds and for how. The way that a lot of these characterization metrics are achieved is through something called surface plasmon resonance, or SPR, which is an optical measurement for determining antibody characterization and measuring binding affinity. What binding affinity means is how tightly an antibody binds to an antigen or a protein like PD-1 and for how long. Because you want it to bind extremely tightly and for a long period of time to prevent it from unbinding and that PD-1 being picked up by a cancerous cell that will then become immortal. SPR machine produces something called a sensogram, which is made up of a couple main parts, but the two important ones are the association and dissociation phases. In the association phase, you have your antibody, which is suspended, and you flow your PD-1 over that antibody. And as the PD-1 binds to the anti-PD-1, it increases the mass and therefore generates an association curve, as seen here. Then once you've reached, you're looking for curvature in this line. So once you have an adequate curve, then you stop flowing antigen, or PD-1 in this case, and then begin flowing buffer again. And then you can see the PD-1 disassociate from the anti-PD-1, and you get a curve as that happens, as the PD-1 or the antibody loses grip on the PD-1 and it falls off. So this is an example of a sensogram. You can see you have the association curves and the dissociation curve. And when you fit this in a program, the program is called Scrubber for anyone who's interested. It's not necessarily important, but it's kind of cool. By the way, their logo is a rubber duck, which I think is hilarious. But if you fit this, then you get something called the equilibrium dissociation constant, which is not really useful by itself as an absolute measurement, but very useful to compare to other antibodies. Because if you run this test on all of your different candidates for antibodies that target PD-1, then you can find the best one, the one that has the lowest number here, and that will be the tightest binder and therefore the most effective drug to target PD-1. Then, therefore, you're good. You can go send this information for dosages to preclinical trials and move on, right? Not exactly. You've made an assumption when you fit this graph that the antibody was 100% active, which it rarely ever is, because in transportation, it could get bumped when it's frozen for hours or days at negative 80 Celsius temperatures. And when it's produced in the first place, it's never going to be 100% active. So how active is it? Because that will affect your comparisons to other antibodies. Using something called surface plasmon resonance calibration-free concentration analysis, we can determine the active concentration of an antibody, not just its nominal concentration. And we do this by, instead of using SPR to focus on how tightly and for how long antibodies bind to each other, we focus on how much antibody is actually binding in the first place. And we do this by, instead of flowing a relatively small amount of antigen over the surface and determining how much binds per second and how long it binds, we flow a ton of antigen over the surface. And that just tells us how much antibody is there and generates these straight lines that we can, again, fit at 4 different concentrations and determine an active concentration, in this case of 41.91%. 41.91% is really different than 100, and therefore it is expected that that will give us different values. So we just said that it has a constant of 2.4 nanometers, the anti-PD-1 antibody. But now we've determined that its active concentration is 41% or 42%. So it now becomes 996 picomolar, or roughly 1 nanometer. That's a really big difference, especially if you're comparing a bunch of different antibodies to target PD-1 that all have different activities. You can't have that much error in your measurements because that's going to mess up your comparisons to different antibodies. And that means you might not actually get the best one. If you're a company researching antibodies and you're trying to determine the best candidate for targeting PD-1 to market, then you are going to be very concerned with the actual comparisons in the best antibody possible. That being said, since this new method has come out, CFCA, or calibration frequency analysis, in 2020, pharmaceutical companies have begun using it because of its effectivity, and not only that, but it's actually helped in determining new antibodies that target. Sorry, I've kind of lost my train of thought here. But many companies have started using this because they also want to determine the best antibodies for their purposes. That's all I have for you prepared today. If anyone has any questions, mechanistic levels, things, or anything of that sort, feel free to ask now.